Okay, good afternoon. I am here in the lab number 4 with Dr. Fava, with Juan, Erika, Alex, Claudio is our tech. Here is Jaime as an anesthesiologist, and Mariano is our anesthesiology tech with crossover from the lab number 1 to here. So we have a little delay here. We are waiting for the lady preparing the valve that he has a traffic problem. But anyway, we have to present the case. So let's go with the slides. Las diapositivas. Okay, perfect. So this is case number 6 in our series of cases. So next slide. So she is an 81 years old lady. She presented with dyspnea. She has history of hypertension, dyslipidemia. She was a former smoker, heavy smoker. She suffered from a hypothyroidism and also a significant COPD. Next. On the ACG, there is under a normal sinus rhythm with 65 per minute. The PQ is 160, but she has a right bundle branch block with a QRS of 160 milliseconds. So this is an important consideration. It's why we are going to use a pacemaker from the beginning, and this patient is gonna keep the pacing at least until tomorrow. Carlos, do you agree?
Yeah, I agree.
Okay, perfect. So under the blood test, she's suffering from a little bit anemia with a normal renal function, with normal platelets account, with a body mass index, sorry, of 26, and the echo Doppler evaluation unveil a severe aortic stenosis with a significant gradient of close to 60, the peak gradient 35, the mean gradient with an area of 0.7 square centimeters, with a Bmax of 4.0 meters per second, with the left ventricular ejection fraction of 60. She also has a significant MAC calcification with a mild aortic, mitral regurgitation. She has suffered from a mild frailty with a Edmonds score of 8 over 17. She is not fertile for this procedure. The STS score evaluation showed is 2.4% probabilities of mortality undergoing the surgery. Next. Proxima. Okay, perfect. This is the angio that we normally perform here. Remember that we cannot perform CT coronary angiography. It's not covered by our health system. So that's why we have to do a regular angiographic evaluation before all the TAVI procedures, especially for these old patients. So she has a quite dominant right coronary artery, huge artery, without significant lesions. Next. So this is the left tree with a normal left main with some calcification, but not significant lesions. Also for the LAD, which is tortuous with probably mild lesion, no more than 20% after this huge second diagonal branch. And next. And this is the orthography that we did because we had a previous CT scan that I will show you afterwards. But in this patient we had before, and we knew in advance that this patient had a low left main and small sinus. So we did this orthography to have a better check of we were observing on the CT scan evaluation. Next. So these are the measurements for the annulus. These measurements were done at the core lab. Close to 20, 19.7 and 25 with a perimeter derived of 22 diameters for the annulus with a perimeter of 71 and an area of 395. So on the right side of the panel, you can observe the coronary ostium height, where the left is 10 point something, 0.8, and the right is quite okay, it's 15. Next. Here we have the photos. This is annulus dimensions, 19.7, 25 with an, excuse me, area derived of 22.4 millimeters for diameter with a perimeter of 71. And on the right is also an important finding that we have to bear in mind because the sinus are quite small. Sorry for the noise. We are open and preparing the valve for the case. So we are preparing 26. It's okay. 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 Sorry for the noise. So the sinus are 26, 28, and 27, as you observe there. So in summary, she had a small annulus. This is very important consideration for our strategy today. Next. So this is the LVOT dimensions, which is almost similar, 18 by 26. So it's not that big. And we have significant calcification at the sinotubular junction with diameters smaller also, or small also, 21, 24, and 22. This is important consideration also for leaving or not the pigtail after the final delivery of the valve, or retrieving before, and also an important consideration regarding left main ostium protection. Next. So this is the calcification of the leaflets. As you can observe there, it's not significant calcification. In our opinion, we can go direct without dilatation to prevent any damage of the conduction system, to prevent a permanent pacemaker implantation. This is ascending aortic diameter, which are also small, 28, 29, 20, 29. Next. And here are the measurements of the coronary height. Thank you, Claudio. This is for the left is 10.8, probably is on the limit or the border for being acceptable and probably for not being protected. But with this small sinus, with this significant calcification of the sinotubular junction, and the other finding I will show you afterwards, we have decided to protect. The right is at 15.4. So this, I mean, high enough for not needing any kind of protection. Next. So this is the finding that we have to bear in mind for our procedure. Next. So this are the projections, working projections, and on the left oblique is the left 14 without any cranial or caudal angulation. And for the near cast overlap view, we are going to use the right one with a caudal inclination of 15. Next. So this is the angulation of the aorta, 46, which is not that important. But there, we have done some measurements of the leaflets, of the left leaflets, which is 12. If we have the left ostium at 11 with the significant calcification of the sinotubular junction, with some, a small sinus, these are the three findings that, drive us to protect the left main, even having a borderline height. So we prefer to be in the safest way. Do you agree on that, Carlos?
Yes.
Yeah, perfect. Okay, next. So are the vascular access. Both are quite similar, about 6 millimeters in diameters. On the right, we have some calcification on the posterior wall. Hopefully, it's not going to interfere with our puncture and our closure devices. In this case, we are going to use ProGlide, of course. Next. And this is the aorta without significant angulation. In the aortic arc, we have some calcification, but they are distal to the left subclavian, so this is not that important. Next. So here in instruction for use, we are in the borderline regarding the perimeter and also the diameters. Next. But according to all the description I have already done about the annulus, the sinus, the ascending aorta, we have chosen in a different way that you usually decide that when we are in the borderline, we always select the bigger valve or the biggest. But now we have chosen the smaller. we have selected the 26 for all that reason that I have already mentioned and to protect this left main. Next. So in summary, it's an octogenarian lady with COPD with severe symptomatic aortic stenosis. So she already had a very clear indication of TAVI, which was suggested by the heart team. Next. And our plan for today is to do TAVI with the self-expandable valve by percutaneous femoral access. And we are going to protect the left coronary ostium from radial approach. Next. So let's go back to the lab. Dr. Carlos has already done the left radial access. Here we are going to introduce the catheter to protect the left main. He also has the punction on the left femoral artery, and here we have the venous access. Now we are going to do the crossover, and we are going to do the puncture of the right side, which is going to be our access site. We are going to protect, as always, especially when we are live. Nothing would be wrong if we can't. So we always try with the pigtail. If something goes wrong, we can use different wires or different catheters, but doesn't seems to be the case. Okay, you put the pigtail there. We have problem with the injector.
No.
Probably we have to reset. Let me do the. Let me ask you to the echocardiographer if he has. No. If you have you done or no?
I haven't done.
Okay. Would you like to check if
Okay.
we have pericardial effusion? I like to do it in advance because some patients, especially old patients, sometimes you have pericardial effusion before. So if you know it, you are not worried after the procedure when you have some finding in the echo control. So we have something went wrong with the injector. It was on, but now it's off. Okay. Okay. While it's just resetting, maybe Carlos would inject manually here while I am doing the puncture here. Please. Okay. No, a little bit down. Okay.
We have some mild pericardial effusion anterior, very little.
Okay.
So now we know.
Now we know. You know why? If we have this finding after the procedure, say, wow, maybe we have a perforation or something like this. Okay. Okay. Oh, it's okay. It's okay. Let me do some avulsion here. Make a traject here. So then we have a perfect movement of the suture when we finish the procedure. We are going to put the 6 French introducer set. We are going to complete the hyperonization with the full doses. Probably we have to check the zero of the blood pressure because I think it's not right.
Okay. All right.
Now it's okay. Perfect. Now it's right. Perfect. Let's go with the O18 wire by contralateral side.
Perfect.
Oh. Once again, we two probe lights. Okay, we are in the common femoral artery. It's okay. We are going distally. Okay. Oh, no, here. Para tu lado. Okay, now we are going to introduce the regular wire for the probe lights. The other important comment is, according to the anatomy, not significant calcification, we are not going to pre-dilate. So Dr. Fava, who is doing our database analysis, have found that the right bundle, the previous right bundle branch block is the most significant predictor for the need of a pacemaker implantation after the procedure. So now we are in, we have a good shed of blood. Okay, yeah, okay. Oh,
Oh,
something went wrong here. We might need another lie. Probably due to the calcium. Voy a mostrarme. Okay. Sí. I don't know if we are going to use another ProLite or the ProStar, because this calcium, I think, is interfering. Because I have problem when retrieving. We have flow here. No, we have. Tráeme un ProStar. We are going to change. We are also use a ProStar. So we will have 6 sutures, because during this maneuver, probably we damaged the artery. Okay, because I have some bleeding
mira atrás de él.
outside the. So I am going to wait a little bit for the ProStar. It's gonna be okay. Okay. Vamos a necesitar. We are going to need the amplats with a short tip. I have backflow here. I close it. And now I am here. I pull the needles out. And now I have the needles here.
Pinzas.
If you can zoom here, what I am going to do now is to pull these needles out. While I have the 4 needles out, I cut the thread. Vení acá, Juan, a comprimir un poquito. Okay, needles out. Hold there. Have here this. And now I had to rescue the sutures. This is 1. This is 2. This is also white. And one of the green is also here. And here I have the additional one. So as you can observe, we have a rail from here and a rail from here. And now we are going to introduce. This is the more difficult part because it's not marked, the orifice. So sometimes it's a tactile sensation. Or you might need a light that I was trying to prevent, but I need it. Yeah. Here. Perfect. So now we introduce the wire. And One is gonna hold the groin. We are going to pull the wire, the prostate out. And we are going to put the 14 French introducer set. Okay. Okay, hold it. Okay. Perfect. We are okay here. Give me the pigtail. Let me clean my hands. See. So now we are going to put the pacing here, the pacing wire here. Okay, we are going to loop a little bit. Everything okay, Jaime? All okay, okay. Now, abajo. Infla. Okay. So this case is from the beginning, just to use all the time we have this hour, because if not, this is the most difficult part in a TAVI procedure, is to put the patient in the right position. Okay. Especially for patients with tricuspid regurgitation, sometimes it's difficult. These wires are okay because they are soft, but a little bit difficult to manipulate. Once again. Okay. Okay. Okay, this is important. The distal balloon to prevent any puncture of the right ventricle wall. Okay, let's go with the 5 French. Turn on off this light. If not, it's difficult for the camera. Perfect. Yeah, no tanto, no tanto. Okay, sí, okay. Okay, now we are going to cross the valve, and then we are going to put this 6 French guiding catheter. Sepáralo, Juan. We are trying to go in, no, here. Okay. In our way. We need sometimes, sorry. Times. Most of the cases are easy. And another, like last week, we had to change for the Amplatz catheter and so on. No yet. We are going to put the coronary catheter. Let me. Can you give me another? It's not good to work with some blood in your chest. Okay. And I will put over this one. Mostrame. So we are going to go from the radial axis to go to the left main. I think it's a little bit catheter. Probably we'll have to exchange. Do you have a cordis guiding? No. Dame eso.
3.5.
Yeah, because the gut sealer is difficult, or guideline then are difficult to put inside this guiding. Let's go with the long wire. We can exchange. Sorry for changing, but I don't like to have blood in the chest. It's okay. It's okay. Okay. Give me here.
Listo, ya está. Listo.
Okay. Give me a wire. Let's change for the corners.
Un segundo.
This is a long wire.
No, no,
Or give me the amplas.
Amplats.
Why I'm using the other brand is Dale. Because these catheters, the other ones, sometimes you have problem to advance. Pero Dios, dame otro. A ver si, ¿eh?
Pero con
So when you put this guiding, you might have problems with the guide extensions. And this is the idea, to use the guide extension instead of putting a stent and a stent in, which is the other way to protect the left main. Okay. Take it out.
Listo.
Give me an extra support wire. Oblicua derecha. Test. Sí. Let me check. Okay, sorry, it's okay. Now I am going to put the wire into the LAD, distal to the left main. I will introduce the guide extension. ¿Qué extensión de guía tenemos? No, hijo.
Decir,
Okay, we are going to use the telescope from Medtronic. Give me one. It's a hydrophilic with an excellent trackability test, Carlos. Okay, perfect. Maybe you can go to AP view. Rotador. AP craneal. Test. Okay. Test. Okay. I need some loop there. Now the wire is destroyed. Okay, no, it's okay. Give me the guide extension. We have already prepared some stents. We have 3.5 by 18 and 4.0 by 20 or 18 also. This is very hydrophilic catheter. So I will show you what we are going to do to protect the left main and be ready to implant a stent if it is necessary. But here we are living in Argentina, we cannot destroy a stent just because. Okay. Leave it there. Is that okay? Now we need to put the 6 French pigtail. It is okay. For the AP, frente. Valve is ready. La válvula está lista. Okay, valve is ready. We are going to check before starting. Now we are going to introduce this, the pigtail for as a marker.
Off here.
Here. Now 15. And let's go to the working projection. Okay, is that okay? Let's move. Soltalo. Here. I think it's okay. One zoom. Okay, perfect. There. I think overlapping is perfect. The position is great. The pigtail is great. We have the guide in there. So now AP view, anterior posterior. Let me reshape the confida wire. And then we will check the wire, the valve. Yes, please tell me. If we have some questions from the audience, anyone who can transfer the question, I can answer. One comment would be if there is another option to protect this left main, because if we have to treat it, at the end of the day, we are going to end up with a chimney technique. But for this old lady, I think chimney is okay. In a young patient could be a problem. So this, here we have the paddles, perfect. We can rotate and everything is okay. So she's gonna have the valve. Now we are going to introduce confida wire. With this pre-shape that we always perform to these wires. Juan is gonna be ready for test. The injector is full. Let's go to the working position. Okay. Vení acá, Juan. Okay. Hold the shift. The wire is on the apex. Now you're holding the groin. Please don't stick me. Okay, and now let's go with the valve. We are going to use for sure commission and alignment, putting the device at the 3 p.m. One is gonna release. I'm going in with the inner sheet. So now let's go to those. Okay. Let's go to the other side. Vamos a usar 120 y después cuando te diga. No, cuando yo te diga. Okay. Now we have trying not to move too much all the other catheters. Here it's important to do what we are going to do, is to protect the left main. Now I'm introducing the Godzilla into the LAD. To have protection, I'm gonna prepare the syringe, inject. Enough to check it, just in case we need it. I may be ready, we are going. Let's go. Let's go. So I think this is an okay position. mini test. Okay. A little bit lower. Okay, pacing 120, 120. Okay. Slowly, slowly. Okay, let's go, let's go. Let's go, Carlos. Let's go. Okay, perfect. Stop the pacing very slowly. Okay. Okay, let's check.
No,
I think the position is okay. Pigtail is a little bit up, but it's okay. Let's see what's going on with the left main. I think it's totally patent. Let's go to the left view. Okay. I will pull the wire so to prevent any distal movement. Inject one. I don't like it. I think it's too high in a valve without significant calcium. Let's go back. Volver. Okay. 120. Okay, pacing. Okay, Carlos, closing. Very fast. Sarah.
Yeah.
Test. There. Let's go. Test. Dale. Okay. Okay, enough. Stop pacing. Inject. Let's go to the left view. Here is a 304. Let's go. And here is okay. I think we are okay. Left main, let me check a little bit distally or proximally in reality. I think it's okay. We can complete the delivery. I will pull back the catheter. Let's go. Let's go, Carlos.
no, sí.
120. Okay. Valve is almost free. No pushing, no pulling. 140. Okay, 140 to stabilize. Let's go, let's go, let's go. Okay, everything okay?
Sí.
Okay. Now, unfortunately, you can see there what I did is to be sure that not losing the engagement with the left main. This is important. Inject is only 10 cc more. So now let's go to the, okay, let's check here and then on the right view. So left main is okay. But you can observe there the leaflets is close to the ostium. Very close. Inyectame un poquito. Very near to the ostium. Once again. Okay. I think we are okay. I will retrieve the delivery and another tip that I use it here is keep it there inside the ostium just in case. I will retrieve the device and then I will check if I need post dilatation. I centralize the nose cone. This is my shaping wire doing this. I pull this, have the set prepared, and we will check it. Why the telescope catheter is inside? Because if we had to post dilate, I still need to protect the left main. I will pull it when I am done, when I have finished. We have prepared 2 cases for today of TAVI with these characteristics. Next one is going to be done after this case, not online for sure. Don't worry. But we are going to do exactly the same. Why I pull the pigtail before the final delivery? Because we have a significant calcification at the sinotubular junction. This is important. Sometimes you have problems to retrieve the catheter in this special situation. So I will inject. We some paravalvular have some paravalvular leak. I think we have to post dilate. Give me a 23 balloon. 23. Okay, one post dilatation. We still have 10 minutes. Maybe meanwhile you can check it while we are preparing the balloon. Okay. Move a little bit. So we will check with echo. So position is okay, but we can see there the valve is a little bit collapsed on the distal end. Can you show the echo, the 3D?
Yeah.
Perfect. You can observe there on the,
We can see that there's no effusion. I mean, the same effusion as
yeah.
that we had at the
Sorry.
beginning.
But the valve is a little bit collapsed. Is that okay?
Yes, we can see it
Yeah.
in the short axis.
Yeah.
But the valve is kind of elliptical.
Yeah. Perfect. Take your hands out.
Okay.
We can observe there the aortic regurgitation in more than 45 degrees. So let's go with the balloon. It's important not having retrieved the catheter from the left main. Now we have to pace him very well at 180. Carlos, you have to wait
Okay.
until the blood pressure is down. Yes.
Dale.
Now, let's go, go. More. Deflate.
Okay.
Okay, I think the dilution was too
Two.
much diluted. Okay, stop pacing. Holding the sheath. Or Dr. Fava is too weak on Wednesdays afternoon. Maybe another chance, another option. I think it's central now.
Thanks.
Could you check it? Or let me check if it is right there. No, something went wrong. Let me check. Let's post dilate again. Wait a minute.
Pues, me parecía.
Okay. Let's go. 180. Okay, Carlos, let's go. Now it's okay. Let's go. Go. Okay. Stop pacing. Okay. Now, please, yes, check with echo, and I will put the pigtail because I don't have anything else to do it, because a bigger balloon is too big for the wrist of the valve. ¿Cuál es la cintura de la válvula? It's 23. So we went with 22, a high pressure with a high volume. So for sure we were at 23. I will put the pigtail, measure the gradient, pull back the pigtail and do a final lunge. May I see a little bit, Turco?
Sí.
Yes. Maybe somebody understanding Spanish can hear why we call Turco, but it's his nickname. Let's go. Let's go. Let's flash. Sorry, we have to check the left main to pull back the.
So we have the same effusion and the valve looks more rounded than before.
Let me do an ancho before, and so you can check it a little bit better because I have the guiding in the Ostium. Now we'll do final test here. Okay. I think it's okay. Now it's time to pull everything out. First the guiding, after the Godzilla, and then the wire. Now, please, let's go. We still have 5 minutes or 10 to go. Carlo, anything different to do it?
No, nothing. It's perfect now. The valve with no gradients.
And I think the paravalvular leak is not significant. And we still need some time to leave the valve opening a little bit much. Now it's as Dr. Mukarcel said, the valve is more circular. And we don't have leak between 12 and 3 p.m. that it was observed, just a very small leak there. This is shown there at 2 o'clock.
Yeah, that's we have two small leaks. The main one is the one that you just said at 2 o'clock.
Diastolic pressure is okay. The curve configuration of the pressure is okay. So we might pull the catheter. We don't have gradient. So we might need a balloon 7. Haga un poquito la mano, Turco. So I will pull the catheter, do the, let's go to the working projection final answer so Dr. Mukarcel can do a better evaluation without the pigtail inside. Okay, we still have a diastolic feeling there in the left coronary sinus, but the other is okay. The height of the valve is okay. In the first bit, is everything is out. Well, okay, it's not absolutely nice, but it's okay. We also have a very nice cusp alignment. You can observe there the left main ostium completely free without any post of the valve facing the left main. Now put it on the AP view so Dr. Mukarcel can keep working to check his finding and final evaluation of the pericardial effusion. Meanwhile, we are going to introduce a balloon from here due to this prog-light disruption. And then we are done. I think we have done something different, protecting the ostium. In case the left main were compromised, the idea is to leave the guide extension inside the LAD to advance protected stent into the left main. And to position in the stent, and when we are sure the position is okay, then we can pull the guiding, or excuse me, the guide extension and deploy the stent. And if we can advance the guide extension again over the balloon of this, or the balloon of the stents, so that we can post-dilate to put the distal stent in case of the dissection or anything goes wrong. Let's, you are in the coronary, okay. So give me some light here. First, we are going to close. Once again, we have to do surgical job here. We have to find each one who is connected with the other one, this with this, and we are going to close the whites first. Carlos is gonna hold in, and Dr. Jaime is gonna reverse the heparinization. Yeah, pull those. It's okay. Let's go. Excuse me. We have something here inside, which is the pigtail. Leave the wire and pull the pigtail. Okay, just in case we need to introduce something else. So Dr. Fava now is gonna pull the sheath. Meanwhile, I'm gonna close the suture. Okay. Very slowly. Carlos is gonna hold it And now we are closing the second suture. Let's tight again. 2, 3, 4. And now the re-entry here inside my fingers. Now closing. Let's see. We still have bleeding there. And now, okay. We are going to close the first dog line. We still have bleeding there. Probably due to this, hold it here where I have my finger. And now I'm gonna inflate the balloon while Jaime is. Muéstrame. Okay, inflate the balloon. 1, 2, 3, 4. I'm gonna leave it here for 4 minutes. Okay. Meanwhile, heparin is going. Yeah, the wire is here. We can pull it because we have control from the other side. We can pull this, all the sutures. Okay. Hold it, hold it. Okay. Hold it. Probably we need a bigger balloon, an 8 millimeter balloon instead of this 7. 8. Deflate, I'm gonna use 8 millimeter balloon. Hold it, Carlos. Oh, this. Okay, hold it. Muéstrame. No, aquí. Okay, okay, perfect. So we are going to inflate the balloon. We wait for the reversion of the heparin. And in case we still have bleeding, we can put an additional angiosin. But before, we have to wait for probably 4 or 5 minutes. So we will finish this offline because our time is almost consumed. But I think what we tried to show you, it was how to protect the left main ostium. It was already done. Here. Okay, inflate. Okay. Okay. Now, Carlos. Okay, hold it. We have to wait there. Put the clock there. We need to wait 5 minutes. In case, once again, if we still have bleeding, we can use an angiosil. If we still have bleeding for this old lady, this is the case that we can use a cover stent without anything else. But now this is the time that we have to wait. On the ACC, what I see, I think it seems there is a little bit delay in the conduction in comparison with the previous EKG. ¿Puedes modificar la derivación a ver si se ve mejor? We'll try to change. Let's see if she is. No. It's okay. No, it's okay. It's because the pacing is too high. Baja. No, but she's under Movitz. You see, I think. We don't know. So put at 40. So we can wait there.
No, 40.
No, 40.
40.
Any comment from the control side on the state? Will you talk me to my ear? What time is it? Hora?
3 minutes, un minuto.
Okay, we still have 2 minutes to go. Anyway, we are 2 minutes here, so we are still 3 minutes at least for compressing. Do you need a holding? No, móvelo para acá. Now we don't have bleeding. That's good. But anyway, we still have the balloon. We can push all the sutures again, just not to move anything else afterwards. This movement of the first proglide probably damage the interside, and that's why we still have some bleeding. And that's why we are going to hold the groin for probably 10 or 15 additional minutes in case we have bleeding. So I think, Jaime, you need a little bit more protamine to do an ACT. Mm-hmm. For these small ladies, still 14 French hole is significant. It's something that we have to pay attention. It's something that still we should be very careful to prevent any kind of complication. Everything should be solved here. Whatever it happens, it's better here. Here we can solve it, fix it, and everything okay. So, Dr. Mucalcel, any final comment of the echo? So you are free.
So the fusion is the same as we saw at the beginning. And we have, as we showed, two little small leaks. The biggest one is the one at 2 o'clock, but they're all in all, they're mild.
Okay.
The gradient is okay. LV function is also okay. So everything looks good.
Perfect. And the gradient? So it's
Here we have a 9 peak of peak gradient and 5 of mean gradient.
okay. That's great. You are free. We are done from your side.
Great, thanks.
Okay. Espera un poquito. We are now 5 minutes. We are going to give the balloon 1 additional minute because the bleeding was significant. And then we are going to deflate and keep holding for at least 3 or 4 additional minutes. And then we will check it. It's like the old area when we hold the groin for big sheath. Deflate, Juan. So balloon is deflated, but we still have to hold the groin for additional minutes. Because if the sealing was not perfect and you release now, probably you are wasting your time of the balloon inflation. So it's better to be sure that you have hold the groin enough time to get the good, closing. So I just holding very softly. We don't have bleeding, but anyway, I would like to keep it there for at least 2 or 3 additional minutes. Do you have any comment from our tech? Okay.
We're ready to go to the next lab whenever you're ready.
Okay, we are done. We have holding the groin, so you can move to the other lab, to the other center.